It's an interesting one. It's really kind of at the intersection of low cost access to rehab, the need for quality assessments, and the fact that that needs to happen at the home, and potentially, how technology can help correct both of those or all three of those problems.
Hey everyone, my name is Dr. Nick Halsey with Motus Nova. I'm a licensed neurophysical therapist and neuroscientist helping brain injury survivors understand how to make functional gains after their injury. I hope this video helps you in your recovery.
And this paper was recently published in Frontiers in Neurology. And the title here is Automated Movement Assessment in Stroke Rehab. And so you are the senior author on this paper. And I'm just interested to understand, maybe not any of the details here necessarily about some of the algorithms and how you're sort of prioritizing things. But I just like to understand a little bit about what was one of the motivations for doing this. What was tell me a little bit about the sort of the path to getting to something like this, and then maybe we can kind of dig into some of the details as they're interesting.
So let's start with the assumption that the possibility, if not the probability, of trying to do more and more rehab in the home environment, just like you're doing now, is going to become more prevalent for a variety of reasons. Convenience to some extent, the increased technological availability, which you all are privileged to make use of right now, quite frankly, and other factors which are more important to some people than others. For those of us living in the Atlanta area, for example, as patients and providers, it takes an awful lot of time to negotiate Atlanta traffic. And for that reason, often patients are more reluctant to have to come at set hours if they have to contend with those stressors. And we all know that traffic can be a stressor in this town or other large urban environments. Anything that we can do to make the communication and ease, which one can relearn in our case, movement activities, easier, is appreciated. The downside to that is that we won't be with our therapist all the time, because they will not have their hands on you at those moments in time. So that's the background underlying the motivation for wanting to do something a little bit differently. You're already experiencing a form of that with a very nice opportunity you have here with Motus, of using an exoskeleton to that you try and help you to control movements at your wrist in a gaming interface with instruction and oversight by Dr. Housley or others, who can then change the parameters of the things you're trying to do from a distance. You should realize that this is not typical. This does not happen everywhere right now, but it does represent a good portion of the future. So between those two ideas that I've just spoken to you, several of my colleagues who I collaborate with at Virginia Tech, and now they've just moved as of last week to University of Southern California in their robotics center, have been working with the concept that you may have heard of before called machine-based learning, or machine-computer brain interfaces. In this particular case, what makes this slightly different from what you're experiencing right now is the opportunity to do very specific tasks and be trained not by the therapist, but essentially by a computer to give you instructions as to what you can do better. How's that possible? The way that works is over the course of many, many efforts on many, many patients, there is a camera capturing motions at multiple joints of the upper extremity, both in people who haven't had a stroke and can do these movements of different tasks, and there are 12 different tasks that are involved in this case, all of them easily identifiable, things from reaching to simulating zipping up a shirt, a zipper, or buttoning a shirt, or moving an object from one location to another. Things that I think it's fair to say we would like to do with either of our extremities under most life situations. Well, even those of us who have not had a stroke don't do these things exactly the same way. We have subtle differences in how we go about doing them. And so what the cameras first do is they capture the motions of people who have not had a stroke, but who are typical of the age. Some people who've had strokes make these movements for these different tasks over and over. So from capturing these motions of multiple joints, the computer fundamentally learns what's normal, what should be expected for that particular movement. And then the programming fundamentally is based upon essentially having the cameras take the information that they see, continuously compare the difference between what is occurring at each of these joints during a task and what should be occurring within the relative differences in able-bodied individuals, and then telling the patient where those differences occur and giving them feedback based upon the amount by which they improve those differences towards being normal. So hopefully this is starting to make some sense to you. So it's camera capture of movement, comparing movements at one or more joints to what should be, and giving a signal back to the patient about the difference between what they did and what should be expected of them to do. Usually it can be in multiple different forms. A visual cue, even a gaming interface, but what makes this kind of exciting, much like you're experiencing right now with the mentor devices, is that the differences between what should be and what you do are also captured and stored, so that over time, as you're improving, the differences between where you started from and where you came, what you can do, then can be shared quantitatively in terms of numbers with the therapist, with the insurance carriers, and demonstrate how the machine interface is helping you to improve in your function. Now, does that mean you don't have anything to do with the therapist? Of course not. It's fundamentally taking, we call it a machine, it's basically processing the visual information from the camera and looking at those numbers in terms of elements of movements at your joints and giving you back information about how well you're doing without necessarily having to have the therapist there all the time to do that. So this speaks to the future. Mm-hmm. What you're experiencing right now is changes that are going on in the parameters of the mentor devices based upon how easily or difficult you are in succeeding for motions in gaming interfaces. But you've got someone who's manipulating that for you, and that's Dr. Housley or his surrogate. The next step or generation is to have fundamentally a computer do that for you. So this paper that Dr. Housley is referring to is a demonstration of a lot of data and information that is leading us into that direction. And we believe, many folks in engineering and in rehabilitation believe that this is the next wave, this is the future. And I think it's fair to say that many of you, or your children, or your buddies and friends, are already used to computer interfaces to help you do something, whether to acquire knowledge or information, or to do something for you, or to get something for you. This is no different. It's just a bit more sophisticated. And we think in this generation and future generations will be an expectation of our patients. So that's really what this paper is attempting to do and set the stage for people to look at it, think about it, criticize it, improve upon it. That's how we progress.
Mm-hmm.
Try to keep
that's the scientific way, Dr. Wolf, yeah.
Trying to keep this in a way you can understand and appreciate, because it could be within a year or two, you're going to be exposed to these very things yourselves or other patients might. But to think that a machine, a device, can help you do something based upon how it's taking input observations of what you are doing to help you seems strange. Maybe it is, but it's not there to replace the therapist. It's there to complement what can be done for you when you don't have the hands-on in front of you all the time.
Hey, if you're finding this video helpful, please hit like and subscribe to help other brain injury survivors learn how Motus Nova is changing neuro-rehab.
Yeah. And they actually work symbiotically, right? I mean, those algorithms need to be trained on something, right? And I mean, at some point, it has some unsupervision where it's trying to learn features that are not necessarily pre-programmed, but it has to have some constraints, right? We know kind of limits of human motion. We know kind of what the ranges are of normal performances. We know what's important to kind of look at, and so a lot of those, it's kind of I think of it as an amalgamation, right? You can try to insert some insight, but then you can rely on the algorithms, which can watch data, look at things that you or I could not necessarily pay attention to, or wouldn't have the capacity to pay attention to. So
yes. So remember what I said, how I started this. I said that this interface, this machine interface, looks at normal movements in a whole bunch of people over and over. And if I was a talking machine, I would be saying, well, what am I supposed to be looking at? You got to give me some instruction here. What's expected? I can tell you whether it's what's going on at each of these joints based upon what I'm capturing, but what's good? What's bad? How do I grade what I report back to the user in a way that's meaningful based upon how much error they're making in their efforts? That's what fundamentally this is all about.
yeah, I mean, just maybe a couple of clarifying things to help everyone understand, Dr. Wolf. So it looks, a lot of people want to know, is it sensing like EMG? Is it sensing just kinematics? What actually is it? Are the algorithms looking at in this case? Tell me what's the sort of base function there for?
Yes.
For what? Yeah.
So we have markers at different places on your arm, your shoulder, your elbow, your wrist, even above your fingers. And what is being monitored by the camera are the movements of those markers as you move. If the markers aren't moving, your limb is moving, but it's tracking the change in the position of those markers in real space. And from that, it can compute a distance or an arc over which a motion is occurring. And it looks at that over and over and over for a given task. And then says, okay, how much movement should there be? Over what time should that be exerted? How straight a curve should it be? What do I do if it's not like that? And how do we fine tune or grade the information given back to you, the patient, if you're not doing it right? Those are the things that are being explored right now. So what's being captured here is motion, not muscle activity. Don't do EMG. Put sensors on your muscles and report back the difference between what the muscles should do and what they are doing. That's even more variable, wider databases than motion. And so that's why you call kinematics. The movements of one limb segment relative to another is what's being captured here by markers that are being put on the skin surface and captured in real space by the cameras.
Now, Dr. Wolf, one potential question for you, and I think you probably know where I'm going with this. I guess there could be two avenues. One, I can envision being, when someone undergoes a rehabilitation program or is engaged in a rehab program that utilizes this sort of technology and interventional approach, they may need to wear special equipment such that their limbs can be monitored in space. Alternatively, I can envision a world where we rely on label-free pose estimation, right? Such as what's done in some preclinical models. And so I'm wondering, where do you envision the future, or is it some combination of the two? Because it might be hard to if we're trying to really think about the problem at hand, that could be a lot of equipment, right? If we have to generate suits and labels for 7 million stroke survivors that might need their this help, that's a lot of investment. So yes. What are your thoughts on that?
So I think things need to be, in a way, prefabricated I can't imagine any patient, no matter how smart or sophisticated they think they are, willing to take the time to have to put on special suits, equipment, special kinds of markers. The interface has to be incredibly simple, accurate, and fast. Or else I can't imagine any of you out there listening to us right now really taking a strong interest in this if you felt this is too complicated. I don't know how I don't want to have to do all of these things. It take too much time. What if I do it wrong? The goal here is to create markers that can be easily adhered to your skin, or it could be a shirt, a fabric shirt that may be provided to you that has a special adherence to these markers, but something that you would not have to spend a lot of time. And there may even be, now I'm making this up because I don't know, but I certainly will hope that there will be a check, shall I say, when the person has everything on. The cameras will then check the positioning of these markers and then report basically saying something's wrong here with the one marker on your elbow. Please check, and you're probably going to have a picture in front of you that shows you how everything should be aligned. And
it says your right elbow is on your left shin or whatever.
Or whatever. I mean, something
error,
say you need to move the marker on your right elbow slightly to your right or to your left or whatever it sees as being wrong. And then you do it, and then it checks it again and says a little more, a little less, or okay. But those could be very quick checks because presumably all of this stuff will be pre-organized and pre-labeled for you, if you will. So if there's some errors that the computer detects, hopefully they'll be very subtle. So it won't take much time. Because no one on this call is going to buy using this notion of a machine to help. It's going to take too much time. Because we're all busy people. We want to be helped, but we don't want to feel like we got to do 100 different things in order to get started. That won't work.
And the other really interesting thing too is when we consider the use of these, we'll call them learning algorithms, right? These deep learning approaches, they do take some training, right? There needs to be some training that needs to happen. And oftentimes there needs to be some training that is specific to the individual it will be applied to. So you also have to put this in the context of there has to be probably some initial period of time where the algorithm is going to be learning about you and you in particular. It might come there with some insight, maybe from the generalized individual, right? It might bound some certain values, like it's unlikely that you're going to be greater than 8 feet tall and, the limb segments be X, Y, and Z. But it does have to be trained. And I actually have some experience with these approaches in my basic science world. And we actually use some really cool technology, and it's called deep lab cut, where it's a label-free approach, where you don't have to rely on putting stickers on a limb. What you do is you give it some training frames. What you do is you go through and you label, hey, this is where the elbow is and a couple of pixels, and this is where the hand and the fingers are, for instance, or this is where my hip and my knee are. And what's really cool is the algorithms can actually learn the features that are extant in those images, and then you don't have to rely on that. So I envision some version of that going forward, where you may just have to say, hey, this is where my elbow is. You may point to your elbow in a live frame, or may point to your wrist, and it may kind of learn those features from you actually performing some sort of standardized task, whatever that may be. But it's really cool to think about. Kind of, we're on the sort of cutting edge of, I guess we're always on the cutting edge, of course, but kind of the next generation of home-based technologies, which is pretty cool.
So one of the things that all of these machines will have in common, they have to know where you are relative to what they're processing, and they have to be able to see any motion in space, in your working space. That's really important. And then the other thing we're learning is, what do we say? What does the computer say to the user that is understandable, not complicated, and facilitates learning, so that you spend your time learning rather than, I wonder if I did this right. So these are all challenges. It sounds pretty trivial, but it's not. Just finding the right interface, the right wording, the right instruction is so critical to optimization of success in trying to interface with these fuel machines.
Yeah. And to that point, Dr. Wolf, I think one of the most important elements here is going to be a collaborative effort between not only the people who are designing this and the ones that are actually sort of deploying this, but also the individuals who use these technologies on a daily basis, right? We have to know and learn from you. How can we best help you? As Dr. Wolf was saying, how do you want your information to be tailored to help you learn? I think that's a critical element that often goes sort of maybe underappreciated, but hopefully we can elevate the import of that component of rehab. And these
I
technologies
would hope to think that any good clinician or researcher can honestly say, they should say, they learn more from their patients than they do from any textbook or any instructional course.
Yep.
Thanks for watching this video. If you have questions or would like to speak with me about how you can make functional gains from home, call or text me at 404-939-3476 or visit motusnova.com/contact.